So good afternoon, everybody. It's a pleasure to introduce this webinar dedicated on the Classica project. Welcome from Strasbourg. We are sitting here at the ERCAT Center, and I have the pleasure to share the floor today with one of the speakers who will also be chairing this session, Pietro Mascagni, that I will introduce lately. But Pietro, just to say a quick word, is one of the most brilliant young scientists in the field of surgical AI and beyond, I would say. But I have the pleasure to share the floor also with Professor Alberto Retto, Professor Ronald Cahill, Rita Rodriguez, and myself, you know me, I'm Silvana Perretta. So for those of you who do not know Classica, Classica is a very ambitious project who is really aiming at assisting surgeons with the use of AI and validating the clinical use of AI in assisting the diagnosis and the real-time decision-making treating of cancer, specifically colorectal cancer. We have a very intense program with 5 speakers. So with no further ado, in order to leave you a little bit of time to interact, I will give the floor to Alberto Arezzo, who is joining from the United States. I hope, Alberto, this is a time compatible with life, that you didn't have to wake up in the middle of the night. But please introduce the first speaker for us.
Thank you, Silvana. Thank you. Thank ERCAT for hosting us today. And thank you, Ronan, for putting together such an amazing group of experts in colorectal surgery. One of them is Felix Anger, that in my opinion, doesn't need any presentation, but in case you don't know him, he's the head of the Department of Surgery at the Hospital St. John on God. And he will briefly give us a speech about the state-of-the-art treatment for rectal cancer polyps. He is consultant in general surgery and visual surgery, and he's also fellow of the European Board of Surgeons and an international fellow of the American College of Surgeons. Not only, he's also an adjunct professor at the Charité in Berlin. So please, Felix, the microphone is yours. And thank you.
Thank you, and good afternoon, everybody on the screen. Alberto, for the nice introduction, and it's a pleasure and especially an honor for me to take part in this outstanding EU-granted project, the Classica project. It's my task now to introduce the state-of-the-art treatment for rectal cancer polyps, which is the major part of our clinical trials in the Classica project, and we'll show you some of the technical issues we are dealing with in the framework of this study. So these are my conflict of interests, and what is our approach in the Classica project? We deal with rectal cancer and with rectal neoplasia, and the approach we use is the transanal one. Transanal minimal invasive surgery is not only good for polypectomy or local excision of rectal neoplasia, as you can see in this nice cartoon here with different layers indicated as we use the intramuscular dissection. I will show you later on, or the full thickness excision in irradiated patients. There are several possibilities you can use with this approach. But apart from this, we also use the transanal approach for the TME. As you all know, in the last 10 years, the transanal TME has been developed towards an appropriate technique to address low rectal cancer by this oncologically radical approach and technique. Other indications are the completion proctectomy and ileoanal pouch anastomosis in ulcerative colitis cases, where the transanal approach is also in a hybrid technique with the abdominal, of course, is a wonderful technique to address especially the highly inflamed region of the rectum. And also the Hartmann takedown is one of the, might say, colibri approaches of the transanal a technique which can be used there. So the TAMI's journey has taken big steps, and it all began in the late 60s with Sir Alan Parkes introduced the transanal excision with the conventional retractor, as shown here in this right bottom cartoon, for addressing rectal neoplasias, rectal polyps as well. But in the 80s, it was Gerd Bues who unfortunately deceased too early from us in Tübingen, Germany, who introduced the transanal endoscopic microsurgery with this rigid system, where still is in use, but he was the pioneer when taking a step into minimal invasive endoscopic surgery through the transanal approach. And this TEM or TIO or TAMI's approach developed the next years through the development of more soft and more flexible ports from the SILS surgery we now use in our daily practice. And the ultra new intervention or approach is the robot one through the single port inserted transanally. This is given by Professor Werner Kneist, who is doing this transanal TME operation with the robot as well. So this is the development of the TAMIs. So when we compare the TEM with the conventional local excision as described by Sir Alan Parkes in the late 60s, you see there's a huge difference in the port system nowadays used for doing these procedures. And even with very low rectal neoplasia, we can use those port systems after beginning with the open approach, as shown in the left bottom picture, with a patient with a low rectal polyp, which was diagnosed as being malignant. But we started with the open approach, the conventional local excision, and then inserted the port and continued and completed this operation with an R0 resection. So when we compare in the studies already published the TEM with the conventional local excision, the TEM improves with visualization, especially with the development of 3D systems, which will be shown afterwards by the next speakers. We, apart from the local excision, we have a stable pneumorectum, which guarantees a balanced insufflation, especially with the newer insufflation systems. We have a better hemostasis control, and an appropriate working area is about 5 to 12 centimeters. As shown in the left bottom picture, it was too low to start with the port inserted, so we had to start in an open approach. So the appropriate area, the perfect area, is between 5 and 12 centimeters from the anal verge. In the history, in the literature, with the TEM, we have a lower R1 excision rate, a lower rate of fragmentation of the specimen, a lower recurrence rate compared to the conventional local excision. What other possibilities are to address rectal neoplasia, rectal polyps by endoscopic submucosal dissection? We have to discuss all the cases with our gastroenterologists who are doing these ESDs, so this is important to know the data about this. So this is a study from Germany, from Augsburg, from Helmut Messmann, introducing 300 cases of large non-pedunculated colorectal polyps with a rate of submucosal invasive cancer cases of about 18%. They did an en bloc resection in over 80% of the case, a recurrence rate of close to 5%, and a complication rate which is acceptable. However, there are pros and cons of this endoscopic submucosal dissection with the conventional endoscope. The pros are, of course, en bloc resections are possible, low recurrence rate, qualitative histology, but the cons are especially those procedures, if they're even done by experienced hands, is very time consuming. sometimes taking hours to remove circularly arranged rectal polyps or adenomas. They're technically challenging and higher complication rate compared to the TEM techniques. And thanks to Alberto Arezzo, has done a wonderful systematic review and meta-analysis on over 2,000 patients, comparing ESD with the TEM technique. And you can see that there is a higher rate on block resection in the transanal endoscopic microsurgery group, which was significantly different. The R0 resection rate is also significantly higher in the TEM case than in the ESCT cases. There is no significant difference in the complication rate, even though the recurrence rate in this meta-analysis is significantly lower in the ESD cases, but even acceptable with 5.2% in the TEM series. However, the need for further abdominal surgery was higher, significantly higher in the ESD cases, also including, of course, the oncologically radical resections in unfavorable histologies. So that is what the EAS brought to paper, that both techniques, the endoscopic as well as the transanal endoscopic microsurgery, are two established techniques to perform local excision. The conventional local excision, however, is burdened by high local recurrence rates and should be abandoned and only considered in selected distal lesions, as I've shown you in our own case. So this is the state of the art for the rectal neoplasia. You can see low-risk rectal neoplasias, including polyps, pedunculated, or even flat ones, can be removed by EMR or ESD by our gastroenterologists or our surgical colleagues doing endoscopies like we do in our department here in Graz. But this should be equaled to the TEM procedure as well. So we decide on the height and the depth of the lesion, what to prefer, which technique, but rather tend to TEM, as you can imagine, from my surgical point of view. In high risk situations, with a PT2 or worse differentiation, as well as lymphovascular invasion or even tumor excision through any approach, but a radical excision following the principles of the total mesorectal excision, of course. So this is a meta-analysis of 13 studies showing the risk of lymph node metastasis in early rectal cancer, as I've mentioned. You see that it is not really the infiltration depth which is decisive following the odds ratios here listed in this table, but more likely the lymphovascular invasion, the grading pattern, as well as the tumor budding, which are more probable indicating lymph node metastasis. So that this brought the authors of this study recently published in Gastroenterology to reconsider the fact that the deep submucosal invasion is a significant risk factor for lymph node metastasis in T1 colorectal cancer, because showing data from this meta-analysis shows up that in the multivariate analysis, 8 studies of beyond 3,000 patients had an odds ratio of only 1.7 for risk of lymph node metastasis when following the deep submucosal invasion as a risk factor, opposed to a significant or more significant association between lymph node metastasis and the differentiation grade on the one hand, and more common in the high-grade tumor budding as well as the lymphovascular invasion. So the authors conclude that the deep submucosal invasion should be reconsidered as a strong indicator for oncologic surgery. And other factors like the lymphovascular invasion, the tumor budding, as well as the poor differentiation are more common to be risk factors for lymph node metastasis. So closing my presentation with some technical considerations we use for these transanal endoscopic microscopic surgery pathway. We need a good insufflation system, as I've already mentioned, a stable pneumorectum, which is offered by different companies nowadays. With a conventional insufflation system, you will end up in a disaster. We need these soft and flexible port systems, Lone Star retractor, monopolar hooks, and so on and so further. So you see some examples. The most important fact about those flexible ports is that the flexibility and the degrees of mobility are much better than in this old, long, and rigid rectoscopes, as you can see in those cartoons, which makes the maneuver within the rectum more easier and easier for the surgeon because of the higher grade of flexibility. Whether you position in the lithotomy or the jackknife position or in the left lateral, it does not matter. It's upon your center experience. You need some devices you use for that dissection, like the monopolar hook. Here's how we do it in our center with the surgeons between the legs, with the insufflation generator and scrub nurse on the patient left side. We use a vacuum matrix for extreme Trendelenburg positioning. Of course, an insufflation system with continuous insufflation and drainage, antibiotic prophylaxis, relaxation, complete relaxation of the patient in order not to struggle with our anesthetist. This is the positioning, horizontal one or the vertical one. It depends on the lesion we address, on the anterior, on the posterior side. For posterior lesions, we handle from the cranial side. These pictures are given by Roel Hams from Amsterdam for our TAMIS course. I thank him for this. And for anterior position, we use the hook from the lower position. So you always depend on the position of the lesion. Here's some pictures from the OR with this lesion on the posterior side, an 89-year-old male patient, endoscopically non-removable. So we turned him to the theater and did an intramuscular dissection with blue injection, marking of the resection margin. And then you can see easily how we get into the intermuscular space between the circular and the longitudinal muscle layer, showing here quite comfortably. We use a hook or the scissors to remove completely remove the lesion and close the defect. We can discuss this afterwards, but we close the defect, and this is the result. The tubulovillous adenoma are resected. And the last picture is the video. We can interrupt if we don't have enough time. Please, moderator, just tell me, but this is a video we can start, and if you like, or it's short of time, we can interrupt at any time. This is a patient who was pre-radiated. So this is a T1 carcinoma full thickness resection, but this was a tumor, a patient who was staged as CT2 and low rectal, a third, and we did an irradiation, and it was not a complete response. Following the TISA protocol, we did a local excision, which was feasible, but it's also depends. So we did a sphincter preserving surgery. You see, it was not completely responded to the irradiation. We had some scarring in the front or anally in the still polypus structure in the oral end. But we did this local excision. I skipped the video a little bit, as you can see also here. In this case, we did a full thickness excision. It was not that easy to come into the intermuscular space. And we did not dare to do this because it was a former T2 lesion. even though the restaging guaranteed it's only a T1, but you never know. So we did a full thickness resection. As you can see, here is the vaginal wall. It's a female patient doing this full thickness. And after all, jump a little bit forward. You can see the vaginal wall and the defect. The defect is closed as shown in this picture. You can even leave it open. Some colleagues leave it open. We close it following an old traditional surgical philosophy. If we do a damage or if we do a defect, then we should close it again. And that is what we did in this case. Thank you very much for your attention. Looking forward to the next presentation.
Thank you,
Felix. It was great. So please go ahead.
Thank you very much, Felix. And unfortunately we are a little bit past time, but the video was so beautiful that I didn't want to stop it, because I think that all the attendees I enjoyed it very much. So it is my pleasure now to leave the floor to Rita, who's gonna introduce the next speaker. Rita.
Thank you very much, Silvana. It is my great pleasure to be part of this project and to see this first webinar. And during this time, that it has been more than 1 year, I had the pleasure to work with Alice. Alice Moinija is a clinical research fellow with the University of College Dublin. And she has been working with the Classica under the direction of Ronan, and now she will present the next lecture, which is Biophysics Inspired in Artificial Intelligence for Colorectal Cancer Characterization. Thank you, Alice. Thank you for joining. You have to unmute. No, I think it's...
Yeah, there we go. Right. Thank you, everybody, and thank you, Rita, and all the team at EARCAT for giving me the opportunity to speak today on this really exciting topic. So I think Prof. Eidner has given us a really nice overview of the treatment of rectal polyps, and particularly the advances that we've had in the last number of decades in terms of a management strategy, particularly with regards to these transanal approaches. However, classifying these tumours as to who would be suitable for such an approach is still a challenge to us. And while some of these lesions are obviously cancer or obviously benign, a lot of the time it's very difficult for us to determine based on a visual assessment alone. We can get some more information from imaging modalities and biopsies, but none of them are perfect. The concern with imaging modalities is that tends to, overstage these lesions, and you end up doing perhaps a more radical resection where a transanal approach would have been enough. And then, of course, biopsy is going to be prone to sampling error, with about 20% of biopsies showing false negative results for cancer. So really, there's scope for us to do much better for patients in this regard. And in an aspect to improve this aspect of patient care, we've developed an AI classification model, which is capable of determining whether these tumours are benign or malignant almost in real time in surgery in the operating room, with a very high degree of accuracy, a sensitivity of 100% and specificity of 92%. And I suppose you might ask, well, how do we do that? We already know that the vessels within cancerous tissues are different to those within normal tissues. Cancer cells stimulate angiogenesis. However, this angiogenesis is unregulated and results in a chaotic network of very leaky blood vessels. And this creates a tumour environment that we know is quite hypoxic and acidotic. And while the tumour can take advantage of this situation to facilitate metastasis, and oncologists have targeted this characteristic of tumours with anti-angiogenic therapies, it's not something that we've tackled from a surgical point of view as of yet. And it begs the question, could we also exploit this characteristic of cancer tissues to improve our diagnostic and classification of rectal tumors? So yeah, we definitely could. But in order to do that, we'd have to have some way to assess this perfusion, to notice the differences in perfusions between these tissues. So many of you will be familiar with indocyanine green, or ICG, which is a fluorophore that has been in medical use since the 1950s. It's given intravascularly and it binds to plasma and is metabolized by the liver with a half-life of approximately 3 minutes. It emits a fluorescent light wherever it goes in the near infrared range. And due to its binding with plasma, it remains mostly within the vasculature in the setting of normal vessels. And so it can be used to assess perfusion in a range of clinical applications. One of the ones that you might be most familiar with is its use in the assessment of bowel perfusion when performing an anastomosis, as is shown here. So just to orientate you briefly, we have a white light image up on the top left, a near infrared image underneath where you can see there's fluorescence in the left half of the screen. And then there's this overlay, which allows us to see both of these together. So you can see the fluorescence from the ICG in the left half of the screen and the absence of fluorescence over here in the bowel that's already been transected. So once we're satisfied that cancer perfusion is different to that of benign tissue and that ICG can easily be used in an operative setting to assess tissue perfusion, we then set about building a model alongside our partners at the time, IBM, that uses this knowledge to classify these tumors. So in this model, the fluorescence intensity of each area selected is quantified and then plotted over time, as you see here, generating these curves. We select both areas of the tumor and of the surrounding mucosa. So as you know, perfusion in general will be subject to variation among patients due to factors such as heart rate, stroke volume, any underlying vascular disease. And so by assessing the perfusion of both the tumor and the surrounding normal tissue, the patient acts as their own control with regard to these factors so that we can be more confident that any differences we see are indeed due to the tissue type rather than due to something specific within that patient. So what happened when we looked at these? In general, what we find when examining these curves is that cancerous lesions tend to have a slower uptake of ICG and then also slower release of it. And this support is supported by the vascular remodeling theory that we already spoke about, whereby vascular flow within cancer tissues is disorganized with increased permeability of capillaries. And what this results in is then some ICG trapping within the tumor itself, and slow release of the ICG over time, as can be seen by the slower release on the curve. Looking at these curves in a little more details, there's lots of features you can extract from them. Of particular interest to us has been the time to peak and maximum intensity and the initial outflow of the curve. And mathematically, all of this can be analyzed. And what we can do with it then is feed each of these curve features into a classification model, which will sort the combination of either benign, the combination of features into either a benign or a cancer classification based on how the case in question resembles known cases from a training set. For those of you unfamiliar with it, KNN classification is a non-parametric supervised learning classifier. So you give the classifier a labeled training set of videos that were cancerous and videos that were non-cancerous, and it starts to notice differences between the two and classifies them according to those differences. And then when you give it a test case, as is indicated here by the blue mark, it can say, well, does this look more like the previous A videos or the previous B videos that we've seen? But unfortunately, it's not quite as simple as that. There's lots of challenges in this process. One of the major challenges is movement. So the camera is handheld, meaning that fine movements can occur. In addition to this, there can be inherent movement within the bowel, as you see here with pulsation. And this movement has to be accounted for using a range of tracking methods. Lots of you may be familiar with AI programs that use video subtraction methods. So that's what you would be appropriate for the video that you can see here on the right. And these models allow a moving object to be detected against a static background. It's typically what's used in self-driving cars. However, in our case, the background isn't static, which adds a different additional challenge to us. So we've been using deep flow video tracking. So this is an opt-flow algorithm whereby a grid is applied to the full image, and then the movement of each square within that grid from frame to frame is detected and analyzed. And so we can then identify where one area of the video has moved to another part. Squares that have been subjected to too much movement, such that their ability to track has been lost altogether, are disregarded and marked as a tracking fail, which you can see by these blue crosses up here. Fluorescence intensity curves are then plotted for all of the squares that have passed this stage, and this can allow an element of quality control into this process. Further challenges that we see then include the presence of reflections along the mucosal surface. So you can see some reflections here along the most anterior portion of the tumor. These areas will demonstrate saturation of the fluorescent signal. And so we have to be able to find them, detect them, and remove them before the point of classification. A more complicated consequence of the photonics involved in all of this is the tendency for areas in the foreground and also in the center of the field of view to demonstrate an absolute higher fluorescence intensity due to their proximity of the light source within the camera. We can account for this in a number of ways, most simply by looking at relative curve features, so the time to peak rather than the absolute maximum intensity, but also by smoothing the curves in accordance to the red, green, blue readouts that are detected from the same region of interest. So in the same way that the area that's in the center, in the foreground, will fluoresce most, it also just looks brighter. And you can tell this yourself, you know, that this area here is nice and bright, whereas down here we're getting into the shadows. And fluorescence will behave in a similar way. So these are some of the curve processing effects that need to be taken into consideration. Then, much like any system, really, the quality of your outputs are always going to be really based on the quality of your input. So making sure that the videos are appropriate for the classifier is really going to be essential in how we achieve this. So in summary, there is a need for better classification of rectal tumors. The principles of altered perfusion within cancer tissues is a target for exploitation for discrimination of cancers and benign tumors. So it's something that we were doing already from a therapeutic standpoint, but it's not something that we've taken advantage of from a diagnostics perspective previously. We know that ICG is safe. We know that it's easy to use intraoperatively to assess perfusion. And we can translate our previous knowledge of ICG management or of ICG use in theatre into this diagnostic role. These subtle differences can be detected by machine learning models, allowing classification. But there is a little bit of work that's involved in that process. And I suppose that then is really what the Classica project is about, which is where our next speaker will be going. So thank you.
Thank you, Alice. Thank you so much. Fantastic presentation. And I don't know if Rita, who's also managing the online group of more than 80 people that is watching, I don't know if we have any question from the audience yet, Rita, or maybe also...
Not yet, Silvana. I think we can proceed. Only the compliments on the presentation. So everything is being crystal clear.
We like that too. Any question from the speakers? No, you really want to be on a strict timing. And so it's my great pleasure to introduce my dear friend, Ronan Cahill. Ronan is the mastermind, as was said before, behind the Classica project, but multiple EU projects. And it's really a pleasure to work with you, Ronan. Ronan is a professor of surgery and director of the Center for Precision Surgery, UCD. He's also driving the digital surgery unit. He has given countless presentations, received multiple awards. He is a scientist, he's an entrepreneur, and he will be talking about the validating AI and classifying cancer in real-time surgery. So Ronald, we are getting really into the meat here of the project. We are looking forward to your presentation. Thank you.
Thank you very much for the introduction. And look, it's great to be at this stage of the project where we have such a talented group to work with, and we're very grateful to IRCAD, who of course is a partner in the project as well. So Alice very nicely explained the current state of the art, along with Felix's talk, that when it comes to big polyps in the rectum, it's difficult to know exactly what their nature is, and that should define what our treatment is going to be as early as possible. And that there is this elegant concept, which is now proven true and working in a computational way, in a prototype model that included up to 100 patients in Dublin and in Amsterdam, showing that actually we can truly verify the nature of lesions based on their perfusion, and this can be exploited in moments during operations, with good background scientific evidence as to why we think this is true. But to really prove it true needs now this exciting collaboration, and we're really glad to be working with such renowned cancer centers and such good people across Europe. We've 5 centres with 3 more to join, but it's terrific to be working with 2 other centres in Ireland, Beaumont Hospital and Waterford Hospital, with John Burke and Peter Neary. Roel Thompson, Yuri and Tierman in Amsterdam have been colleagues with us with other projects, and of course are very expert in both TAMIS and TATME. You've heard already Felix's expertise in Graz, and Alberto Arezzo in Turin brings a lot of clinical but also scientific and technological expertise to the project. And Joep Nol in Belgium too is also now set up to join the project. And we're hoping too that Antonino Spinelli's group in Milan will also join. So no doubt that there is clinical expertise and reach into patients in this important group of people with significant rectal polyps. The Classica study, though, is more than just a surgical trial, and we have other partners with great expertise to help us with this. With regards to development, of training documents and protocols, we're working with IRCAD and the EAES. Have a robust software method, requires high-powered computing expertise, and that's coming from Arctur in Slovenia. And then consideration of the bioethics, the legal aspects of moving towards decision support needs also a specific type of expertise, and that's being provided to the project via the Civil Center in the University of Copenhagen, with American perspective and expertise coming from Sarah Gerke and Penn State. Now, to get all this working together requires some funding, of course, but also careful project management, and Pintail, a group who are making sure that we're meeting the various milestones of the projects on time. So this is the stage we're at now. Arctur have developed a lovely method, as Alice was talking about, of making the videos useful, that there's a capability to see the tumor, annotate the areas of important regions, the abnormal areas with the normal areas, and then capture the fluorescence inflow into these different areas over the course of a project. That needs a lot of robustness in how the imagery is tracked, stabilized, that the time series curves are extracted, and the parameters are then fed into a classifier. So that the first 18 months of the project, from the high-powered computing point of view, was to make sure that we can trust reliably the curves that the inferences are being made on. And with that stage now done, we're really excited that we should be launching the software in each of the clinical sites over the next three months. And we should indeed have it started in April here in Dublin, the first live use of the software, all in one go, all within the workflow and the time of the operation being done. So that then the curves then can be fed into a classifier, and we can start to generate then the results from it. From a clinical trial point of view, we broke it into 3 different structures. The first phase was really just validation of the underlying concepts, and we know now that we're seeing the same types of patterns in the patients recruited to the trial in Classica as they were in Dublin and Amsterdam. So this does seem to be generally true across different patient cohorts in different countries, in different European countries. And also the usability of giving ICG for this cancer identification indication and generating the videos does seem very acceptable to both the clinical teams and to patients who don't seem disturbed by this idea that we could get better visual information by the addition of a surgical dye and some added time to their operation. And that enables us to move towards then the more interesting parts of the study, that with the software in place, we can look to see, do we get the same results from the digital analysis as tissue biopsy, and could it potentially even replace forceps tissue assessment for some of these big rectal polyps? And the third stage then, assuming that we've gotten high levels of accuracy of the tissue characterization, is to see, can we solve the problem of margination of these rectal polyps? And that's represented in a randomized controlled trial of a surgeon with Classica technology versus a surgeon without it, to see can we get better evidence of margin-free involvement for benign and malignant lesions. So yeah, so study 1, we have the prototype now optimized, it's robustly working, and we've been able to compare the existing recruited patients with the previous preliminary work done. So we should be moving towards freezing that prototype now and deploying it in the different clinical centres. That's the conclusion of study 1, is using the software in it in parallel with the procedure. But then as we move towards study 2, which should be in about 3 or 4 months' time, hopefully with ethics approval, we can start to compare its accuracy with guided biopsy, either done at the time of colonoscopy or done at the time of transanal assessment of the lesions. This will need a heat map display to show the greatest areas of anomaly to the surgeon, who can then sample the lesion to try and get better representative samples of it. And of course, it's possible that we could be concluding that study feeling that the Classica software may allow avoidance of biopsies, which can cause some problems due to the time that they take, due to the fibrosis that they can cause, and due to the fact that as things currently stand, they may not be representative. Study 3 is now deploying it for real-time guidance for TAMAS operations. That's contingent on a successful study 2, but that's a randomized controlled trial of about 50 patients per arm and blinded pathological analysis to see can it improve clearance rates of lesions in the rectum. Mindy's going to talk next, but the ethical and legal sides of using AI assistance is really very interesting, and there hasn't been any cases yet in surgery, legal cases taken based on outcomes from AI-assisted healthcare, because there isn't any really AI assistance yet available in operations, despite lots of theoretical and research interest in AI. Actually, in surgery is not something we're currently using. So the Classica software needs to examine and be confident in its role in this area to it. Currently, the liability sits with the surgeon, and it's terribly interesting to consider how that may be changed if the surgeon isn't making all of the decision, but is getting a contribution from a computational component to it. And of course, the EU is just finalising its new AI Act, which will set some boundaries around how we consider and categorise these aspects, with what the regulatory agencies will be taking advice from. So Mindy will talk next about some of the issues that we're coming up with, but that's been a very interesting part of the consortium conversations, is understanding how to work in the legal research context. So this is our patient accrual rates, as was the case about 1 month ago. You see that there's 3 centres open, which is great now that Beaumont is open, and also Turin and Belgium are very soon to start recruiting patients also, which is exciting. And this is the cohort that we've been able to compare with the precedent group to show already that there is confidence in the generalizability of the base assumptions. As the other centres open up, we expect to catch up with the expected monthly recruitment so that we'll power through study 2 and get to study 3 also within the remaining duration of the project, which can be seen here that our total recruitments is we're confident that we can climb up these curves. So in summary, it's been a great trial to be involved with. It's fantastic to have such vocational and interesting partners to work with. The momentum behind the recruitment is now increasing. Deployment of the software in operations is imminent. And I think a lot of the really grinding hard work is done. And while there's more to do, it's more about really seeing it working in theatre, which is a very exciting aspect of it. We've always sought to be transparent and open in the project. Terrific if people are interested in collaborating. There's a variety of ways you can do that and a variety of perspectives that are needed to make this work. So opinions from the audience or from people you know who might be interested in this area are really, really welcome too. So I'm going to conclude there. I'm interested to hear the rest of the talks, and also really looking forward to the panel discussion. So Savannah, thank you very much.
Thank you so much, Ronan. I see that there are 2 comments. I don't know, Rita, if they're just, once again, greetings or if we have questions.
Yes, we have one question for Ronan. Thank you, Ronan, for a brilliant presentation. This question is from Diego Zambrano. Do you think there will be a new TMA classification based on these technological tools in the future? And then it will come like, how do we validate this sort of technology to come to a more standardized classification systems?
Yeah, I mean, I think that's a really great point. And I mean, of course, any new technology has proven to be accurate, but for sure, if this is giving important information that affects the categorization and the treatment of the patient, of course, we should be bringing that forward. I mean, we're already quite comfortable with having a radiological T and M score that we base a lot of our decisions on in the MDT. So of course, we could have a technological contribution to that. I mean, I don't really see this as being being antagonistic to radiological classification, but I think it should be used alongside it. So, and it's interesting too to think actually could some of the perfusion processes that we're identifying for rectal cancer actually translate into a type of an MRI dynamic perfusion test. They already do that in breast cancer. So it's a similar type of concept as what they're using there, but there are some differences in how the algorithms would work based on the tissue texture and as well the vascularity of the lesions to it. So I think, Diego, that's exactly right where this should go.
Perfect. Thank you very much. And one quick question for Alice. If you can elaborate at least in the number of the blocks in the grid, like this is a function of compute, or could you explain a little bit about it?
Yeah, so that's a really interesting point. When we started doing this, we were manually drawing a handful of boxes. So maybe 1 or 2 boxes on the tumor, 1 or 2 boxes on the normal mucosa. Obviously, the more areas that you're interpreting, the more information you have. So that's why now we have the full field of view that is of good quality undergoing analysis, which creates all of those boxes. We have toyed around with the number of boxes. So the greater each box, you get the median fluorescence intensity for that box. And the more boxes you have, the more granularity essentially you will have in your data. So you're able to say hopefully perhaps this part of the tumor looks quite cancerous, maybe this part looks a little bit more benign. So it gives you much more detail, but that is at the expense of computing power. So you could keep going with this down to almost pixel level, but then you would be into hours and hours and hours of computer processing time. So it's about trying to find a happy medium in between.
Brilliant. Thank you very much. I think we can move forward.
So it's with big pleasure that I introduce Professor Mindy Nunes-Dufork, which is a member of the Penn State Dickinson Law Research Team working with Classica. She's an assistant professor of private law and a member of the Maastricht Law and Tech Lab at Maastricht University. Her research focuses on comparative health law and technology with an emphasis on medical liability. And that's what she will present today in this seminar. So it's a pleasure for me to give you the floor. Thank you very much.
Thank you. And thank you to the entire Classica team and also ERCAT for making some space for a lawyer today. So as Professor Cahill said, all of this amazing work by the clinical partners raises some very interesting legal questions. So I will try to address some of those today, focusing primarily on the issue of liability or liability concerns. So I thought I'd start a bit with some general framework for medical liability, general principles that govern medical liability both in the US and also in Europe. So there's sort of two big buckets of liability, or that we can separate liability into. And one governs the behavior of humans. So this is what we would refer to as negligence or fault. And this can apply to clinicians, hospitals, or manufacturers. So actually, I shouldn't have said humans. I should have said this governs behavior of legally responsible persons. The other big bucket of liability is product liability. And so the sort of main elements required for product liability are listed here. So you would need first a defective product, and then that defect would have to cause the damages that the patient suffered. So there's many exceptions to stating this so generally, but this is kind of the gist of how we look at medical liability. So moving first to negligence and kind of zooming in on medical negligence, again, we can separate down into negligence of clinicians, which we refer to often as medical malpractice. And this applies those same behavioral standards that I talked about, but here they're standards of care in medicine in the relevant area of expertise. And so these are determined by medical experts in those specific areas. And then we have also organizational negligence. So hospitals or other healthcare organizations can also breach these kinds of behavioral standards of care, but they're not necessarily in medicine because they're not practicing medicine, these organizations, but they're more in the area of risk management. So this deals with negligent implementation of different tools, maybe in the OR, negligent training of staff, negligent monitoring. These sorts of things will fall into that bucket. And then finally, and this can get a bit confusing because manufacturers can be held strictly liable for product liability, but they also can be held under member states or in the US under general negligence laws for their own negligence in negligently designing or manufacturing a product or in providing certain warnings or information. So they kind of are held to this standard as well, but it essentially merges with the standard that we'll talk about in a minute for product liability. So now zooming in to the standard of care for surgeons or for any clinician. We have these different sort of influences on the standard. So I already said that these standards are decided by experts in the field. And these are sort of based on generally accepted practices, evidence-based guidelines, guidelines from professional societies. But then we also see other influences on the standards of care. For example, whether or not, if we're talking about a medical device or use of a medical device or implementation or training staff to use a medical device, whether or not that device has been legally marketed or approved by a regulator, right? So this kind of regulatory review and market authorization that we'll see pre-market. And then also patients and payers can a bit influence both regulators and the standards of care in the sense, of course, they don't determine the standards of care applicable to medical practice, but you may see patient advocacy organizations start to lobby or for their members for certain kinds of treatment. So one example to bring it to an AI medical device is a medical device that sort of general practitioners can use in their offices to diagnose diabetic retinopathy. So you'll see the American Diabetics Association, which is a patient advocacy association, say, hey, we would like this to be available to our patient population. And they can put pressure on both insurance companies to start creating CPT codes, which then can influence whether or not this gets sort of uptake by clinicians. And so it's not, I sort of have a direct line here, but it's not a super direct influence. Of course, the medical profession itself determines what the standards of care are. Kind of hopping over now to product liability, there's kinds of two things that the law will look at, or two tests that the law might apply to determine whether a product is defective, right? So we don't have absolute liability in the sense that if there's any injury that stems from a product, there's just automatic absolute liability. First, that product has to be defective. So how do we determine that? And this gets really difficult and really interesting when we're talking about AI models or systems, because it can be hard to determine whether or not they are defective or whether they are functioning as they're supposed to function, but perhaps maybe not always giving the 100% right answer. So here to the two tests that both, again, EU and US apply, although I'll give the caveat that consumer expectations is really the leading test that we see in the EU's product liability directive, and it sort of maintains its position as the leading test. And the newly proposed product liability directive asks this very vague question, which whether or not this product provides the safety that the public at large is entitled to expect, taking all the circumstances into account. So again, I'm not sure that this obviously clarifies what a defective product or what a defective AI model is, but it does give some broad guideline about how we can consider that. And the product liability directives gives a few more considerations that can be taken into account. The other test that you sort of see more directly applied in the US, but also applied by member state courts in determining product effectiveness is this kind of risk utility test, right? So it weighs a product's risks and benefits to measure whether it's unreasonably dangerous. And this can include considering whether or not there's an alternative to the product that's being used. And so one of the kind of common examples of this is, I think it's the treatment for rabies, right? So they say, well, the benefits, even though this can be very dangerous, we don't have any other option. And the benefit of administering this treatment is, in this scenario, is kind of a risk that we have to take, sort of an accepted risk. Okay, so where do potential problems come in? As you can see, probably already, the legal system sets out pretty broad rules for governing liability. And for the most part, new technologies can be sort of governed by the framework we already have. but we do see the framework start to be stressed a little bit when we use AI. And particularly when an AI is functioning as it's designed to function, right? So we don't have a design defect here. The AI is functioned to give a prediction or give a diagnosis or give an output or give a recommendation. And it's not promised to be right 100% of the time. That's, as I've been told many, many times by surgeons and other clinicians, there is no 100% in medicine. So it's functioning as it's designed to function, which is not to be perfect. And the manufacturer has complied with the safety regulations that relate to the development of this model and its marketing. So it's giving the proper information, the proper warnings to both, let's say, hospital organizations that are using the model and the clinicians or the surgeons themselves. So the safety regulations that I'm referencing here, Professor Cahill has already sort of mentioned the new AI Liability Act, so that can apply, of course. Also, the medical devices regulation. So any sort of regulatory devices that ensure that medical products that go on the market are safe to go on the market, right? So it's a very broad category of regulations. And then, so now we have down to the individual organizational level, we have healthcare providers. So we don't have that kind of organizational negligence that I talked about. Let's say the hospital system, implemented this. They were perfectly reasonable in how they implemented it. They did it in the right population. They trained their staff. They made sure to monitor for errors, etc. And the individual surgeons also are implementing and using the AI as it's designed. The problem comes when, in the case that an AI system gives an output that's wrong. And the question is whether or not a surgeon or another clinician, but here let's focus on surgery because it's unique in the sense that surgical decisions have to be made very quickly, and they're often irreversible. And the question is whether or not surgeons can rely, if they're entitled to rely on the output of the kinds of AI models that are functioning as designed, market approved, complied with safety regulations, and implemented responsibly by the organization, right? And so sometimes this can be because the big question can arise because the AI is giving some information or making some sort of algorithmic reasoning that gives an output to a surgeon, and the surgeon either cannot in the moment completely take the time to understand why that decision is what it is, or because technically it's impossible if the system is a black box system. So this is, I think, a really crucial question that arises for surgeons because of the time-sensitive nature of the decisions that they have to make in surgery. So something to think about, and as Professor Cahill said, we haven't had a liability case yet, so it's hard to know how this will turn out, is whether or not this kind of gap is just a risk that's inherent in receiving care that uses AI-driven tools that where their benefits outweigh the risks, and the patient has the information about the tool, the physician has the information, the surgeon has potentially had a conversation with the patient. Is that just a risk inherent of treatment, or is this a gap that's just going to be too big? And we do need to find some sort of liability solution for it, because right now the AI's reasoning process or decision making, even though it might be one of many, many, many decisions that's made in a surgery, is not always connected to a legally responsible person, and the AI itself is not a legal person. So this can present a bit of a gap in the current liability frameworks. I think so for now, the biggest thing to think about if using an AI tool in the OR, assuming, again, as Professor Cahill said, we don't have these cases because these types of tools are not yet in the OR, but liability law especially is very reactive. So there's not going to be probably definitive answers about liability or how the standards of care might change to incorporate the use of these tools or might change to allow surgeons to rely on these tools before they actually are put into use. In this case, then it's not that different than any other kind of clinical guidelines that exist. They provide a sort of standard or status of the current sort of state of medicine or surgery. But of course, they don't dictate what the surgeon must do. The surgeon is going to make their own decisions. And the important thing is documenting. I'm sure I sound like a broken record, as every other lawyer does, about making sure you document decisions and patient treatment. But truly, in this case, the big question that surgeons often worry about is, what if I get an output and let's say it says, okay, this is cancerous, but I make a decision because I think it's not, and the AI was right. Or what if the AI gives me a decision and I am using my own clinical expertise and I don't quite agree with it, so I don't follow it. Turns out that it was right? So those are the two big scenarios that we hear often in terms of liability kinds of concerns about implementing these types of tools. And the thing that I can say is to make sure you document the reason, just like you would with a clinical guideline, about why you are or are not choosing to rely on or follow, if it's a recommendation, the output that's coming from the AI, because you're the surgeon and you have used your own expertise and you're dealing with a patient with their own set of conditions. And I think for now, that's the approach to take. It's not that different than departing from a current clinical guideline. Of course, the question is how might guidelines change in response to these types of tools? That's yet to be seen, but it's something that we talk about within the Classica project, and we hope to do a bit more legal and empirical research on to give some predictions. So that is the end of my presentation. I will stop the screen share. Yes.
Thank you very much, Mindy. I don't know, we have one previous question from perhaps Ronan. They were asking if there is possible to determine sphincter involvement in low rectal cancer with this technology. So
yeah,
what would you say, Ron?
Yeah, I mean, we think that the ICG signals are coming from some millimeters deep in the tissue, so there should be some distortion of a T2 lesion, T3 lesion versus a T1 or even a benign lesion to it. So we didn't have enough numbers in the preliminary study to show that, but as we accrued other centers over the course of the project, we're really interested to try and see that. Not just can we tell cancer from not cancer, but can we tell more invasive cancers from the most superficial ones. I think there's a question there too for Mindy, has just come up as well, Rita.
Yes, thank you very much, Ronan. Yes, Jan Ban says that in the EU, negligence liability is not harmonized, so there may be still particular solutions to bridge the gap out there. And if by any chance you come across interesting national member state rules in your research.
Yeah, so I haven't come across any member state rules I think that would specifically bridge the gap, but I think what you can find in member state rules is the control they have over sort of the legal process. We are seeing an effort to harmonize these kinds of evidentiary rules with the AI liability directive, although we haven't seen any movement forward from that in a few months. That would make it easier or give the patient or the injured party some kind of evidentiary help to get proof because it's very difficult to understand how these systems work, in addition to the difficulty of understanding what's happening maybe while you're unconscious in surgery. And so I think the biggest thing I would say, I think, is similar to that, the burden shifting rules that you see in some member state laws. So there's some really strong, I think, rules already that would shift the burden, and that might give these kinds of presumptions of negligence. Let's say if something's considered to be a gross error, or if something's considered to be kind of under the umbrella of what the organization has control over. And these kinds of cases can certainly slip into those categories, I think, especially if it seems that there is a gap and judges or legal systems are looking for a way to fill them. Those evidentiary rules with those strong presumptions, that's the closest thing I've seen.
Thank you very much, Mindy, and such an interesting topic. And since we cannot provide right now a clear guidelines, what we can do is to guide surgeons. So it is my great pleasure to introduce our next speaker, which is Pietro Mascagni. Pietro is a brilliant gastroenterologist to be, and also a brilliant scientist that has focused his research work in artificial intelligence. And he will speak about the guidance and the training in the intraoperative use of artificial intelligence. And I would like to thank Pietro for joining us today and to give this lecture.
So thank you very much, Rita, and thanks to all the panel. It's going to be difficult to speak after you. So as Rita introduced, I'm a surgical trainee at Fondazione Policlinico Gemelli of Rome, and I'm a clinical research advisor in computer science and AI at the ESU Strasbourg, where I did my own PhD on the topic on surgical data science. And for today, I was given the very interesting yet hard topic of what surgeons should know, how we should train surgeons to use intraoperative AI. So as the speakers before me mentioned correctly several times, AI is still not in operating rooms. So throughout my talk, I will try to reason with you, to discuss with you about things we should consider. First of all, we should frame what AI, what more specifically machine learning is. Machine learning, AI, deep learning, it's so powerful because differently from classical programming, we don't need to know every detail of a problem in order to solve it beforehand by writing a software. But this software gets optimized by iterating over data. Data is how the machine gets experience. So the first thing we need to consider when we speak about an AI system is the input data. So the question that we ask the machine. So in this case, probably the question to ask ourselves is that kind of data available? What's the quality of that kind of data? Is there enough signal in that kind of data? And I think there the idea of the hypothesis, which was later confirmed, that the perfusion signals highlighted by a tracer like ICG could speak for healthy versus cancer tissue was a very good hypothesis, and I'm super happy that Classica already demonstrated this. So for this first step, we can say that the data is there, the signal is there, and acquiring it wouldn't necessarily change the workflow. So this is already a very good first point to consider. Then we need to consider what we ask the machine. So this slide is a big simplification of the various tasks that we can formalize in computer vision. Fundamentally, these are classification. So we ask a machine to pick between classes. Another task could be detection, which we not only ask the machine to take a conclusion on a class, but also to localize it in space, for instance, localizing a surgical instrument. And we can go down to asking the machine to classify the full scene at the pixel level, and that's usually referred to as segmentation. So as the speakers before me introduced, the task of Classica is a classification task. So we ask the machine to classify areas of the images as showing cancer or not. A couple of thoughts on this. And I think Alice already did a very interesting comment on it. The task could have been formalized also as a detection task. You need to find the lesion and to give a name to this lesion, healthy or cancer. But for the consideration of clinical use, so the need for low computation, the need for increasing the information, it was preferred to apply a mask on the full scene. So so the task of Classica is classification, and it has some advantages over formalizing the task versus detection. Third point we need to consider is how do we model the reality? So there's very different ways to try to solve the same problem. And this is particularly true when we speak about AI, that is a field that evolves basically on a daily basis. There are two big families of AI models: machine learning and deep learning. So deep learning, properly speaking, is a subset of machine learning. But let's say the usual distinction in between the two. Machine learnings are the first methods that appeared in AI, and these usually use low dimensionality data, like could be tabular data or could be curves, like in the case of Classica, and usually use functions, models that are less parameterized than deep learning models that we will see in a second. So the pros of this machine learning approach is that these are much simpler. Simplicity here is a big advantage, because simplicity means we can inspect this model much better, so we can explain them much better. And also simplicity means that there are less parameters, and if there are less parameters and we apply these techniques to a data set that is not too complex, then probably these methods, this model will generalize better. So long story short, the more parameter you add to a function, the higher the likelihood that this function will overfit, so will copy exactly your training data and will not work on unseen data, so will not generalize. So those are the pros and cons of machine learning. Deep learning, which is a big family of models that can be defined as more parameterized functions, usually that have multiple hidden layers, are powering many of the recent successes in AI that we currently use in our daily lives, from vision models to language models like GPTs and the many likes. These are very, very useful to examine unstructured data, like could be language or images, are extremely powerful, but are much more complex and so much more difficult to inspect or explain. So again, to reconduct this general discussion to the use case of Classica, Classica infers parameters that relate to fluorescence intake in the tissue and represented in a curve. Different features can be extracted from that curve and can be fed into a machine learning classifier that has two different classes. So it's a binary classification, which we will see is going to be represented as a probability. Then we need to think about how to bring this technology in operating rooms. And as it was correctly said many times, this has not been done yet. One could think about bringing compute inside the operating room as we did in a partnership with NVIDIA, we were able to do back in 2021 the first AI-assisted laparoscopic cholecystectomy, which was an important technical proof of concept. We needed to show that it was possible to have several deep learning systems, so computationally heavy system, running on the same time concurrently in real time. And it was feasible. Another solution that companies, especially in flexible endoscopy, are deploying is moving this computation to the cloud. So rather than moving compute inside the operating room, you move data outside of it. Data gets processed in the cloud and predictions are delivered back to endoscopy suites or operating room. Of course, this has its pros and cons and depends on local infrastructure also. Then a third approach to bringing AI in operating rooms is doing that through a platform. So the most obvious platform could be a robot. Here I'm making an example of an add-on to laparoscopy, which adds a sensor, but also adds some computation, which is yet another interesting way to bring this technology to operating rooms. In the case of Classica, the very smart approach was trying to decrease as much as possible the computational needs so that any compute device or almost any compute device could first grab these curves, then extract features from the curves, and then run the ML, the machine learning classifier. And here it's important to remember that probably picking a machine learning approach rather than a deep learning approach, besides the liability concern that Mindy well introduced, probably played a role also in the economics of computation. Finally, we want prediction to be clinically usable. So this is a video of the proof of concept we did a couple of years ago. Here we optimize everything to be extremely visual. We did basically make everything explicit because here our point was to show that it was possible. Currently, there's a lot of work going on to make this kind of prediction usable. So you want a case level prediction. You want to know for that given patient, what is the best recommendation. You don't want a frame-based prediction. Similarly, as surgeons, don't think in a binary way. We think about with confidence. So the machine should give us prediction with the confidence of this assessment. And finally, we want to interpret what the machine analyzed in order to give a certain recommendation. And these kind of thoughts were implemented in the latest version of Classica. So if an initial version had the need for first some operators defining the input and basically contributing to its process, and then the final output was binary, a more recent iteration of Classica prevents the need for having an operator operating the tool in operating rooms. Sorry for the wording. Then there is an advanced video processing. So as Alice was saying, it analyzes the whole image and it gives prediction with their confidence and also analyzes the quality of the input that is fed to the machine. So these are all considerations that after the briefest courses we did should ring a bell on the improved usability of this system. So this slide is meant to basically summarize a little bit what the Classica consortium has done in order to facilitate the clinical translation of surgical AI. In fact, here we show the opinions of more than 500 surgeons that replied to a questionnaire we did some time ago here at IRCAD. And their biggest concern for the use of AI in operating rooms was the lack of the technical infrastructure to run these models. We have already seen now Classica worked on decreasing the compute needs for such a system to be used in real time. Then this pool of surgeons identified the lack of application of surgical value as the second biggest barrier. And these are, I think, Classica, from its very inception, and also probably due to the fact that so many expert surgeons are contributing to its development, it's something that it's in the design, so clinical value from the very beginning. And with the diversity of the consortium that is tackling this problem working together, there's also been the more management and trust issues, both related to how surgeons interact with it, but also how surgeons, where the liability lies, are taken care of. I will conclude my talk with another slide from the same survey where we asked surgeons how willing they were to use surgical AI. And if half of them, so 1 in 2 surgeons, is willing to use AI during their procedures, this goes up to almost 100% after they get to know what AI is. So this task present in the Classica project of training surgeons to favor the translation and use and uptake of this new technology into practice for benefiting surgeons is a commendable one, for which we are organizing with the EAS a masterclass in which Classica is well represented. And at ESU Strasbourg, we are organizing a full week of hardcore collaborative work between clinicians and computer scientists for endoscopic video analysis. Registration for both are still open. I would invite everyone interested. And with this, I conclude, and I'm more than open to any question that there might be. Thank you very much.
Thank you very much, Pietro. I think there was no one better than you to give this talk. It's very crystal clear. And I have to say also that Pietro is a leading expert in artificial intelligence, but not also that. He's part of the EAS task force, which will help to follow and track all the progress of the Classica project. And before giving the floor to Ronan, I would like to inform all of you that soon we will be releasing a newsletter. So if you want to stay in touch with all the news regarding our Classica project, just please stay tuned to the IRCAD announcements. So thank you very much. And I give the floor to Ronan.
Well, thank you, Rita. We're right on time to conclude at 2:30. I'd like to thank everyone for attending and listening. I'd like to thank all our speakers. There was quite a lot there packed into 90 minutes, and I appreciate all their expertise, not just at the presentations, but all throughout the project and the consortium. So this has been really great. Rita, thank you to the IRCAD team for hosting this. We're open for questions and collaborations, and fantastic to hear other people's thoughts. Thank you.